And welcome to today's sessions. Before I begin, I just want to take a moment to recognize Elena Sturman and her team for this incredible effort to make this meeting a success. And really for catapulting the Glaucoma Foundation into this century. Also, I want to congratulate Lou Pasquale again for the Robert Rich Award. That was well deserved, and congratulations, Lou. This morning we are going to continue and re-emphasize our focus on the glaucoma patient by looking at non-IOP dependent factors in glaucoma. And these are things that are critically important both to the patient and to clinicians, because they're things that patients ask us all the time. How can I change my lifestyle, my diet? Can I smoke? Can I drink coffee? All these different types of things. How do my systemic diseases affect me? And then how does glaucoma, of course, affect my daily living? And the things we have to go through to explain that to the patients as well. Many of them are probably online here today listening to this interesting conversation. Our first speaker today comes from Harvard. Jae-hee Kang, as you heard yesterday, is collaborator with Dr. Pasquale also. And is well-versed and published in many of these issues related to diet and glaucoma, and that's what she's going to speak about today.
Thank you so much for the nice introduction. I'd like to thank the Glaucoma Foundation, Dr. Pasquale, and the organizers for this really tremendous opportunity to talk to you today. I've just learned so much from all the talks, and I'm very inspired by all the presentations. So the focus of my talk will be looking at studies of diet as a risk factor for glaucoma development, but it might provide some insights into thinking about what we might be able to recommend for patients with glaucoma. These are my disclosures. So as an overview, I'd like to cover the importance of evaluating diet as a risk factor, and then discuss some important methodological issues to consider in nutritional epidemiology, and finally present some dietary factors that we've evaluated to date listed here. So why study diet? So studying diet is important in the US because some of the leading causes of death and disability are diet-related diseases, including heart disease, type 2 diabetes, and obesity. So much so that there are some researchers that were calling COVID a diet-related disease, given that most of the people who are susceptible are either obese or have type 2 diabetes. Those primary prevention efforts to promote a healthy diet is cost-effective, broadly applicable to the general population as a public health strategy. In addition, as clinician colleagues have told me, diet is of great interest for patients trying to manage their condition, as well as for a general population more and more interested in wellness and living longer. Also, the White House last year held in more than 50 years and committed to the national goal of reducing diet-related diseases by 2030. And expanding research on diet and nutrition. So in ophthalmology, the study of nutrition and disease etiology has yielded specific nutritional recommendations for either preventing or slowing certain eye diseases. For example, AMD with the AREDS formula, plus encouraging greater leafy vegetable intake and greater omega-3 fatty acid intake. Cataracts, antioxidants, diabetic retinopathy with a healthy diet to regulate blood sugar, and dry eye, omega-3 fatty acids. However, for glaucoma, there currently are no universally accepted dietary recommendations, and also I can say no major consistent dietary risk factors have emerged, and comparatively speaking, there have been fewer studies of diet in glaucoma, although the numbers are increasing. So given glaucoma's strong association with age, intraocular pressure, and blood flow. Dietary factors that either lower intraocular pressure or slow the process of aging or enhance ocular blood flow may play an important role. So what are some of the methodological issues in studying nutrition and glaucoma? And I want to touch a little bit on this because every day in the newspaper, we find that, oh, something is related, would increase your risk of that. And then the next day it's the opposite. And it just feels like the Wild West out there sometimes. And one really needs to come armed with some critical thinking skills. And you can forget all the rest, but I think maybe thinking about how to critically evaluate studies might be important. And some of the challenges of studying diet and glaucoma include the characteristics of the disease itself, glaucoma, and there's great heterogeneity in how disease is defined, and therefore standardizing results from one study to another makes it especially challenging. Also, there's heterogeneity in etiology, as can be seen with high tension, normal tension glaucoma. In addition, there is this insidiousness of the disease that can lead to surveillance bias. Because if glaucoma can be picked up with greater frequency of eye exams, and often it is the healthiest people with the healthiest diets tend to get more eye exams, then this might lead to a finding where a healthy dietary component is actually associated with a higher risk solely because of surveillance bias. So also studying diet always incurs some measure of some errors in measurement, and there could be biases that occur when you look at post-glaucoma diet as a proxy for diet before diagnosis. As diet might have changed after a glaucoma diagnosis, or your diagnosis somehow changes your ability to recall your pre-diagnostic diet. Okay. So what are the challenges to studying diet and glaucoma from the exposure or diet perspective? Looking at diet itself, it's very challenging in that they are by nature very complex. If we, for example, look at coffee, it's well known for its caffeine content. That's why we drink it. But it also has over 1,000 unique biochemicals, including polyphenols that are synergistic or have opposing effects. A second challenge, of course, is what was wonderfully covered by Dr. Khawaja in his first session, that associations with diet and glaucoma likely depends on genetics, but it also depends very strongly on one's current nutritional status. So this is a classic curve that every student of nutritional epidemiology has to study. If we divide the population into those with poor on the left, adequate, and then excessive nutrition status, what we see in this curve is what a dietary intervention might do to physiological function. So if you apply a dietary or nutritional intervention in those who are deficient or marginal, those on the left-hand side, by going from left to right, you have this dramatic effect. But as is often the case, if we do a trial of volunteers who tend to be healthy and they tend to have a well-nourished, their baseline nutrient level is going to be near the top. So bumping them up just a slight bit really is not doing much to the physiological function. And that's why we have study after study, randomized clinical control trials that find no association or no effect of the supplement. However, often if you look at the subgroup analyses, it's often there that you find some interesting findings because the subgroup findings are really targeted to that poor, the left-hand side. And one thing also to note is often happens with supplements that people think that more is better, but more is not necessarily better, and can be worse when your intake is excessive and reaches a toxic status. Okay, I put in this slide just again to emphasize what Dr. Kawaja emphasized, which is that it really depends, the effect of a dietary factor really depends on genetics. He had illustrated it with the genetic PRS for glaucoma, but this is in relation to the risk of heart attack, right? So coffee can be considered sort of like Jekyll and Hyde, in that if you're a slow metabolizer of caffeine, so you drink a little bit of coffee and you're jittery for the next 5 hours and you can't sleep, you're a slow metabolizer. If you're that type of a person, then all the adrenaline and all of the negative effects of caffeine might outweigh any of the potential beneficial effects of the polyphenols that we can ingest. And so for the group on the right who are slow metabolizers, increasing your intake of coffee is actually associated with a higher risk of a heart attack. Whereas on the left, if you're a fast metabolizer, you drink it, coffee goes out of the system pretty quickly, and you drink it over a long term, then all the polyphenols and the beneficial factors in coffee have a chance to have an effect. And so really this again highlights the importance of personalized nutrition. And so we jump right into looking at the first topic, which is coffee and alcohol, which in nutritional epidemiology are really the best measured dietary exposures. So we're interested in coffee as a risk factor for glaucoma for a few reasons. Caffeine, the main reason why we drink coffee, does transiently increase intraocular pressure, particularly in those with ocular hypertension or glaucoma, and as we have seen in those with genetic predisposition. However, coffee may have protective effects on our glaucoma risk in that it increases the ocular perfusion pressure in the short term, and coffee is considered a major food source of antioxidants in the American diet. Coffee also has anti-inflammatory effects that translates to lower diabetes risk and greater neuroprotection. And while these mechanisms are relevant for all glaucomas, coffee may also increase the risk for exfoliation glaucoma by affecting the TGF beta pathway and modulating calcium levels, which exacerbate the formation and maintenance of exfoliation material. Exfoliation syndrome is a systemic condition that's characterized by the pathological production and accumulation of abnormal fibrillar extracellular material that can ultimately cause glaucoma. So to assess diet in research studies, a commonly used tool is the Harvard Willett Food Frequency Questionnaire, which has been widely adapted globally, including in the UK Biobank. And this was developed by Dr. Walter Willett, shown here. And we had the idea that if you can come up with a list of about 130 foods of a certain serving size, and you present them to research participants, they can estimate how frequently they ate each food item on average over the past year. And the advantage of this is that it's asking participants to assess their usual habitual eating habits compared to, say, what is done with a 24-hour recall. In a 24-hour recall study, participants are asked about what they ate the previous day. And if you happen to be a participant asked to do this the day after Thanksgiving, you might wonder whether the researchers are getting an accurate picture of your usual diet. We were very fortunate that the Glaucoma Research Foundation had approached Dr. Willett many years ago about the idea of studying diet and glaucoma, and provided the initial grant funds to launch our studies of diet and glaucoma in the Harvard cohorts. I've had the extreme privilege to collaborate with Dr. Lou Pasquale in studying diet and glaucoma in 3 cohorts of 289,000 health professionals, the Nurses Health Study, Nurses Health Study 2, and Health Professionals Follow-Up Study, where the same group of participants have been followed for at least 30 years with questionnaires every 2 years and a food frequency questionnaire every 2 to 4 years, as shown in the blue dots. With multiple assessments for diet and the continued follow-up, we've been able to evaluate in prospective studies the relation between diet and glaucoma. We have accrued about 3,000 cases, incident cases to date, And single-handedly, Lou has personally reviewed all of those records, confirmed all of them. And really, these studies would not have been possible without the dedication and support from Lou. And also, we have to thank the many clinicians in this audience who have filled out the glaucoma questionnaires that we've been bugging you about, because we ascertain glaucoma diagnoses via these glaucoma questionnaires about our nurses participants. So in an early study of coffee and caffeine, we observed that overall caffeine from all food sources was not associated with primary open-angle glaucoma. However, when we evaluated higher intake by family history, we did observe that those consuming about 3 cups or more of coffee had a doubling of risk of a POAG with high tension, but only among those who reported a glaucoma family history. And as presented earlier by Dr. Khawaja, this modification by genetic propensity was confirmed in the UK Biobank, where it was only those with the highest glaucoma genetic risk score who had higher intraocular pressure and a higher glaucoma prevalence with higher caffeine intake. Last year, about a similar time, in a Mendelian randomization study of this topic that is less prone to the biases inherent in many epidemiological studies, those who are genetically predisposed to consuming more coffee had a higher risk of glaucoma, providing further support for this topic. In our cohorts, we evaluated whether caffeine consumption may also be associated with exfoliation glaucoma specifically, and we observed that 3 or more cups of coffee was associated with higher risk, which was again especially pronounced in those with a family history of glaucoma, indicating that for those with family history, limiting coffee intake to no more than 2 cups of coffee a day may be something to consider. On to the next topic of alcohol. Some of the mechanisms hypothesized as to why alcohol might matter is that for 50 years it's been known that alcohol transiently lowers intraocular pressure, and alcohol may also increase blood flow to the optic nerve, and the polyphenols in wine that give its color has antioxidant properties. However, in the long term, high alcohol consumption does increase blood pressure, which may increase intraocular pressure. And for exfoliation glaucoma, higher alcohol seems to increase TGF beta-1, which is a key player in the formation of exfoliation material. And also alcohol does seem to compete with retinoic acid for certain dehydrogenases, and this competition leads to a pro-fibrotic effect. And so when we looked at this a while ago, we didn't see much of an association, although there was some suggestion of an inverse trend. An excellent recent systematic review by Stewart et al. In Dr. Khawaja's group looked at the existing literature on alcohol and glaucoma very carefully, and investigators observed that there was notable heterogeneity that just looking at current alcohol, yes or no, allowed for a meta-analysis. And overall, it was found that there was a modest 18% greater risk with consuming alcohol. And of course, as a major addition to this literature, Dr. Khawaja had previously presented the data from the UK Biobank that observed that higher alcohol consumption was associated with higher intraocular pressure, higher glaucoma risk, as well as thinner intraretinal OCT measures. Again, the association between higher alcohol intake and IOP was most evident among those in the top 20% of glaucoma genetic risk score. However, this gene-environment interaction was not observed for glaucoma prevalence, and the Mendelian randomization study looking at genetic propensity for alcohol consumption in relation to IOP or glaucoma were not significant, although it was for one of the retinal fiber thickness layers. Finally, in relation to exfoliation glaucoma, the studies have been few, given that it's rarer than primary open-angle glaucoma. In this study led by Dr. Hanyuda, to boost our statistical power, we analyzed the data with the eye as a unit of analysis, and we observed that those who drank about a serving of wine or 15 grams of alcohol per day had about 55% higher risk. And unlike with coffee, where we observed that associations were strongest in those with a family history, Here we observed that the associations were somewhat stronger in those without family history, although the interaction was not significant. Overall, my read of the alcohol and glaucoma literature is that the findings are less robust than with caffeine, and I believe that's just sticking to the national dietary guidelines of moderating alcohol intake by either abstaining or drinking moderately with at most 2 drinks per day for men, at most 1 drink for women per day is sensible for glaucoma risk. Next topic, antioxidants. So our cells are constantly under threat from reactive oxygen species, and this occurs inevitably when we turn food into our fuel or when we're exposed to toxicants like the air pollution that we experienced, or radiation, or cigarette smoking. And our antioxidant capacity to defend against these include endogenous enzymes, as well as exogenous factors such as vitamin A, C, and E that we get from the diet. And when this balance is disrupted, it can result in genetic mutations and cell death. And oxidative stress is very relevant to glaucoma because it is believed to be what causes increases intraocular pressure. And also retinal ganglion cells have very high energy demands, and so the mitochondria are in high energy production mode. And this itself generates reactive oxygen species, which can further damage mitochondrial function and sets up a vicious cycle that ultimately can lead to retinal ganglion cell degeneration. So antioxidants were a natural candidate for study, especially back in the 1990s when they were all the rage. Despite the excitement, in our study published back in a long time ago, 2003, we did not observe any significant associations with vitamin A, C, or E overall, though we did find some suggestive inverse trends with higher carotenoid intake and vitamin E from foods, but not with supplements. In a 2018 meta-analysis done by Ramdas et al., they observed that while there were no associations with vitamin C and E, there was a suggestive inverse association with vitamin A. However, this was based on few studies, and there was some heterogeneity across the studies. So I would say that this is not very conclusive of vitamin A as a single nutrient being the most important for glaucoma, and that it suggests that perhaps food sources of vitamin A may be important. And the reason for that is that various randomized clinical trials of antioxidants as single nutrients, such as vitamin E, have been really disappointing in relation to cardiovascular disease and cancer. And actually, one trial of beta carotene and lung cancer found that it increased the risk of lung cancer. And the idea that you can take a single antioxidant nutrient and put it in a pill and hope that it would prevent disease made sense at the time, but in retrospect was too simple-minded. The reason is that, for example, the effect of eating strawberries of a certain amount of vitamin C is going to have a different effect than the same amount from a supplement, because in the strawberries are the polyphenols that give it its color that actually synergize with vitamin C to have a greater antioxidant response. And it also has other effects. Also, as was seen in the beta carotene and lung cancer example, it is thought that if you take too much of an antioxidant, it might have a pro-oxidant effect. Another simplification was that inclusion of the most common form happened to be the less effective form. So for example, there are 8 forms of vitamin E, and gamma and delta tocopherol are thought to be the most beneficial, but it was alpha tocopherol, which is most common in the blood, that was used in trials. And therefore the field sort of after this disappointment sort of shifted to evaluating other components in the antioxidant foods. And so we went back to the food sources of antioxidants, and one group that got us excited were the green leafy vegetables, as 2 studies from Dr. Coleman's group has shown associations with greater kale intake. And also at the time, we're really focused on studying nitric oxide signaling alterations. And so And at the time, nitric oxide donation had emerged as a potential therapeutic target in its ability to lower intraocular pressure and to enhance ocular blood flow. And although nitric oxide is mainly generated endogenously, when there is hypoxia or this pathway is compromised, the nitrite, nitric oxide pathway is an alternate source, and dietary nitrates would have the effect of increasing nitric oxide. I remember being quite excited to read what Ramulu et al. Stated in their 94 paper. A plate of green leafy vegetables such as spinach contains more nitrate than is formed endogenously from all nitric oxide synthase pathways in a day. So when we evaluated this in our cohorts, we observed significant inverse associations with nitrate intake, with about 21% lower risk in the highest quintile. When we looked at green leafy vegetables, which accounted for 57% of nitrate intake variation, we observed that compared to consuming a third of a serving of green leafy vegetables, consuming about 1.5 was associated with 18% lower risk and 48% lower risk of POAG with paracentral loss. And we believe that the stronger inverse association with POAG with early paracentral visual field loss is consistent with evidence that this subtype is more strongly associated with vascular dysregulation. And since our study, there have been other studies, and most notably the Rotterdam study confirmed our findings. Another dietary factor is flavonoids. Flavonoids are polyphenolic compounds present in many common foods, and they have really multiple biological activities. They reduce oxidative stress, of course, they improve ocular blood flow. And while I'm not very familiar with the literature on potential supplements that have been studied in glaucoma patients, I know that several of them tested the effect of flavonoid compounds or extracts of sources high in flavonoids. When we evaluated this, there were two subclasses that were associated. We looked at a variety of foods, and we identified one hot tea as being inversely associated. And a study using the NHANES data from Dr. Coleman's group had confirmed that, although we didn't observe this inverse association in the UK Biobank, possibly because of the very high consumption there of tea, that maybe the caffeine adverse effects are starting to outweigh some of the benefits. Who knows? Moving on to, how am I doing on time? I'll just try to rush through. Okay, sorry. So moving on to the next topic of macronutrients. So macronutrients of carbohydrates, fats, and proteins provide us with energy, and that's why they're called macronutrients. But they also provide, have other effects important in disease processes, such as inflammatory processes in the trabecular meshwork, as well as neuroinflammation is implicated. And long-chain fatty acids, so the omega-3 fatty acids, most common in fish, are known to have anti-inflammatory and neuroprotective effects. And as we all know, carbohydrates can spike our blood sugar and lead to insulin resistance. So a while ago, we evaluated the relation between various types of fats and POAG, and overall didn't observe an association with total fat intake or major subtypes of fatty acids, although we did observe a somewhat inverse association with monounsaturated fats. Among the polyunsaturated fats, we did not observe that intake of omega-3 fats or omega-6 fats, which are mainly vegetable oils, overall was associated with a risk of POAG. We did report a rather curious finding where among the polyunsaturated fats, if we fix the intake of total amount of the polyunsaturated fats, but we look at the ratio of the 3:6 ratio, we observe that those with a comparatively higher omega-3 intake compared to 6, for example, like having an intake above the median for omega-3, but being in the lowest quintile for omega-6, was associated with about a 68% increased risk. Compared to being in this diagonally opposite group. So having a high omega-3 to omega-6 ratio, or in other words, having a low omega-6 to omega-3 ratio seemed bad. This was rather contrary to our hypothesis, and at the time we couldn't quite make sense of it and thought this was a chance finding. Fast forward to this year when the study from the WHI was published, and I sort of got to maybe better understand the curious finding that I observed many years ago. Dr. Thasarat Wacharanat and Liu were involved in this WHI study. And very briefly, the WHI dietary modification trial was initiated back in the day when it was thought that high-fat diets were evil and low-fat diets needed to be encouraged. And this massive dietary trial over a 6-year period put 23,000 women on a low-fat diet. So overall, the findings were null for the main outcomes of the trial, which were cardiovascular disease and cancer. And I'm always pretty just amazed at what the trial was able to do, which was to lower total fat intake by almost 13% of total calories versus 3% in the placebo group, as shown in this report of change in intake over a year from the trial baseline. Participants also increased their fruit and vegetable intake, whole grains. In addition, omega-6 to omega-3 ratio went down more in the intervention group. Remember that my curious result was that low omega-6 to 3 was actually bad. So the intervention group was lowering this ratio even further. When investigators evaluated the risk of POAG ascertained using Medicare linkage, they did not observe that a low-fat diet had a significant effect on glaucoma risk. However, they did report that participants in whom POAG developed showed a lower omega-6 to 3 fatty acid ratio and lower percentage of calories from total fat at baseline compared with participants who did not. And because of this confirmation, I looked into this further. And while omega-3 gets all of the attention, the American Heart Association says that both 3 and omega-6s are heart healthy, and that one of the major ways that omega-6 fats are protective is that it improves insulin signaling. Okay, so I might just skip over. And one of the interesting things was that this intervention was actually detrimental for women who were actually already on a very low-fat diet, and it was also detrimental to Asians. We know that studies have shown that Asian Americans and Pacific Islanders have higher rates of diabetes than whites and are prone to developing type 2 diabetes at younger ages and lower body weights. Okay, so let's see. So we conducted something opposite, a study of looking at something opposite, which is a plant-based low-carb diet. And overall, we did not find an association, but for those with paracentral loss, we observed that higher an interaction where this low-carb diet was actually associated with lower risk. Okay, and then in this study, we had available blood samples from 10 years prior to glaucoma diagnoses in roughly 600 cases and 600 controls, and we looked at the association with incident glaucoma, and we had similar data, thanks to Dr. Khawaja, looking at glaucoma prevalence. And what we observe is that triglycerides really popped up as being adversely associated, and triglycerides are a strong marker of high sugary diets. And also the ones at the bottom that are inversely associated are ones that are markers of mitochondrial function. So those of you who know about the keto diet or know about the butyrates that are efficient, that help with mitochondrial function and efficient energy production. And again, this was also more stronger associations were observed with paracentral loss. Finally, dietary patterns. The MIND diet, which is developed for lowering cognitive decline, has been developed, and the Rotterdam study has looked at this, and they found that those in the highest quintile actually had a halving of the risk. And the two elements that were most accounted for this were green leafy vegetables and also berry intake. Okay, so just to wrap up, I believe that nutrition studies will continue to be a research priority for the scientific community, and the NIH has launched a precision nutrition program as part of the long-term strategic plan for research priorities. And the goals are to incorporate genomic and other factors that may allow for dietary, where dietary responses are different by personalized factors. So with that, I'd like to thank all of you for your attention and thank the funders of our work, including the Glaucoma Research Foundation. Thank you.
Thank you, Jehi, for that tour de force through this topic. Fantastic. I guess my grandmother was correct. No smoking, no drinking, eat my spinach. And next year, Elena, when someone asks for a glass of wine or a cup of coffee, you're going to give them a bowl of kale. Okay? So hypertension and systemic blood pressure and blood flow are critical issues, of course, for glaucoma patients. There was also the SPRINT trial that our internal medicine colleagues did. Was stopped early because in that study, they forced blood pressure very, very low and was associated with increased longevity. Of course, the eye was not studied in that study, and there is absolutely no data. We're fortunate to have one of the world's experts on ocular blood flow and perfusion here with us today. Alon Harris comes to us from Mount Sinai here in New York. I'll turn the podium to him. Alon.
Thank you, Jeff. I woke up very proud today. I'm very proud to be on the board of the Glaucoma Foundation. It was such a great meeting. I learned so much yesterday and today. Thank you, Elena and the team. I woke up proud because I have my friend Lou received such a great honor yesterday. Also my neighbor, office neighbor, and just proud that I can still consume some alcohol, some caffeine, and still doing okay. So I'm gonna try and tackle this topic of blood pressure and blood flow and so on. These are my disclosures. They don't really pertain. This work that I will present, some of it is from our NIH grant, and actually on the last part, we just received our JIT, so hopefully next meeting we'll have more information on the next grant. But I will try and tackle the issues of hypertension, but I'll put it in perspective with low blood pressure, which is really been where glaucoma, where we have been concerned about low blood pressure, but I'll show you today that we should be concerned about high blood pressure as well. I'll deal with hypertension and IOP. I'll deal with microvascular damage secondary to hypertension. And we'll look at some OCTA data, new data relating to hypertension and cardiovascular disease. And I'll end with something related to our math models and machine learning to possibly predict glaucoma progression based on blood pressure and IOP. Still a lot of work to do there, but this would be a good forum to just sort of kick it out there. This has been a topic that has been discussed since 1800s, and I almost got scolded with stones only 30 years ago when I brought it up, and the blood flow topic was really not very popular then, and we've come a long way since the days of Van Graefe and Priestley Smith. And I remember we discussed this in one of the first think tanks in the 90s, and we're still here, but I think we've also got some answers. Let's try and clarify. Low blood pressure, there's certainly a plethora of studies that show that low perfusion pressure is an important risk factor for glaucoma And it's interesting because the many different population-based studies actually indicate the prevalence, but also incidence and progression. And I think that's, that's where it gets convincing when you can actually have it in all those different levels. And that's also where in 2009, 2008, Bob Weinrep and I published this one book on the from the consensus meeting, where based on the population data, finally we got elevated to be considered, we meaning the vascular risk factors, the low blood pressure, low perfusion pressure, recognized as an independent risk factor. But the story really gets a bit more interesting and maybe complicated. I'm one of the PIs in the Saloniki study, and in Saloniki in 2006, 2013, one of our reports has been related to low blood pressure. And what we found is that only when we stratified the blood pressure to different levels of blood pressure, the diastolic perfusion pressure was was associated with glaucoma patients only in those using antihypertensive medications. So this is not something that we could see in patients that are not taking these medications. We had the first paper in AGO in 2006, the second one 2013, and they both confirmed the same. We could only see structural changes in those patients that had low blood pressure with taking antihypertensives. There was confirmation to that data that came out of the EGPS as well. It's always nice to have data like this confirmed, where diuretics and other antihypertensives actually presented with quite a high hazard ratio for glaucoma, suggesting there's something there. And maybe later on and in the discussion, we can discuss some of the mechanisms. But this chapter, I want to conclude in saying that the data from Saloniki and others suggest that low blood pressure with antihypertensive treatment is associated with increased risk of glaucoma to structural damage. This paper, when we came out with the data and the consensus meeting in the early 2000s, people said, that's interesting, Alon. It keeps on coming up in the population-based studies, but we haven't seen data related to progression, okay? And since then, there's been a number of studies. I picked a recent one for you from IOVS by Lee et al. And this is to determine risk factors associated with structural progression in medically treated normal tension glaucoma. And they had looked at the peripapillary retinal nerve fiber layer or at the GCIPL. And what they looked at were factors that are associated with progression, and found disc hemorrhages, diabetes, and systemic hypertension as important risk factors. In fact, when they took it the next step and they performed a tree analysis, they showed that systolic blood pressure could be a stronger association with progressive peripapillary retinal nerve fiber layer. More specifically, they performed the Kaplan-Meier analysis and found that eyes with a minimum of systolic blood pressure or less than 108 showed more progression than others. On the diastolic side, the Kaplan-Meier revealed the same, except that was a minimum of diastolic of 63 millimeters, and you can see even bigger separation from progressors to non-progressor, suggesting the diastolic blood pressure actually played a relatively more important role here in terms of progression. So yes, we do have data that ties in blood pressure with progression. So they concluded that the tree analysis identified blood pressure target values that may slow glaucoma progression, that low blood pressure measured during follow-up correlated with structural progression in medically treated normal tension glaucoma, again, in medically treated, and this is a theme that we should get to discuss. High blood pressure. So we're really looking at a continuum, and high blood pressure can be damaging. Low blood pressure has issues with perfusion, and I want to just take you through a little trip as I was requested to deal with high blood pressure today. The issue of where hypertension fits in is also impacted in the different studies depending on how they defined hypertension. These are the new definitions by the World Health Organization, and you can see normal being 120 to 80, where elevated is considered over 120 already, okay? And stage 1 hypertension is 130 to 140, 80 to 90. Stage 2 is over 140 over 90. I take the time to emphasize this because if you look at previous definitions, they're different. So these data or these definitions that were put together in some of the ophthalmology papers might have yielded different results. For example, the JNC, which is the Joint National Committee of Prevention, Detection, Evaluation, Treatment of High Blood Pressure, it defined blood pressure earlier, where 120 to 130 was considered pre-hypertension, and later on the definition or it was changed to be considered elevated blood pressure. And what was pre-hypertension at 130 became to be stage 1 hypertension currently. And then stage 1 became to be stage 2, meaning that the cardiologists decide, or their data support the fact that we need to be more aggressive about blood pressure treatment. And so that will depend, those values really can impact the population-based studies that looked at it over the years. This is a study that investigated glaucoma risk associated with blood pressure in unaffected antihypertensive treatment. So we're looking at blood pressure without treatment. We see 3 groups: elevated blood pressure, stage 1 and stage 2, according to the 2017 definition. And this is a retrospective observation cohort study taken from the National Health Screening data from Korean National Health Insurance Database. They had over 360,000 individuals, and you can see how these large groups of patients are divided to the normal blood pressure, elevated blood pressure, stage 1 and stage 2. They performed Cox regression analysis to calculate the hazard ratios. And what they found was they followed, in their study, they got data up to 11 years, with 3.56 being diagnosed with glaucoma. And in the multivariate adjusted hazard ratios, they found that elevated blood pressure presented a risk, and certainly as blood pressure increased, that hazard ratio increased as well. They concluded that the risk for glaucoma increases with increased untreated blood pressure, and that stage 1 hypertension is a significant risk factor. In evaluating the literature and preparing for this talk, I came across this important study. This is a meta-analysis that analyzed the association between systemic vascular risk factors, including hypertension, diabetes, age, and migraine as well. And they pooled the data, and from the pooled analysis population study between 1990 and 2019, and reported that hypertension was the most significant systemic vascular risk factors out of the ones that they looked at. Again, diabetes and migraines, and as well as comparing it with age. So I'm a physiologist in background and like to make sure I review the mechanisms. What about hypertension and IOP? We heard this come out through different times during the discussions yesterday and today. This is a meta-analysis in AJO that looked at 60 observational studies. All studies reported a positive association between blood pressure and IOP, and the pooled average increase associated with a 10 millimeter increase in systolic blood pressure presented with a 0.26 millimeter change in IOP. Likewise for the diastolic blood pressure. And the meta-analysis concluded that these findings support the role of increased blood pressure in elevated IOP and possibly in the development of glaucoma. Anthony gave us a nice talk yesterday, and this comes from the UK Biobank, and he showed this slide looking at the relationship between intraocular pressure and blood pressure. Both the Goldman and the corneal compensated IOP measured were significantly associated with high systolic blood pressure. And further, in looking for this evidence, there's a paper from 2022, which again examined all the different studies that are out there. And you can see when they try to answer the question of does hypertension increase intraocular pressure, the vast majority of them again reported that it does. Again, they use different definitions, and still overall the studies showed this association. So when we talk about the effects on intraocular pressure, these are some proposed mechanisms. One is related to the sympathetic activity, stimulation of the cervical sympathetic activity, leading to reduction of the cross-sectional area of the Schlemm canal, according to these studies by Liu, and reduction, and that will lead to increase in the outflow resistance and intraocular pressure, and these are studies from rats. Also, increase aqueous humor secretion secondary to increased hydrostatic pressure rarely. Increasing blood pressure increases perfusion pressure in the ciliary arteries, which can increase the rate of aqueous humor, of course. And finally, the renin-angiotensin system, where this system is seen in both, where angiotensin II exacerbates hypertension, leads to vasoconstriction. We know this in cardiovascular physiology years ago. Increased secretion of aldosterone and proliferation and increased collagen synthesis of the vascular smooth muscles, further exacerbating the situation. And this, of course, will increase intraocular pressure. I want to visit now in the lines of evidence I'm presenting to you with hypertension and microvascular damage overall, also examining the brain briefly because we have a lot of similarities between blood flow control between the eye and the brain, and ultimately end with glaucoma. So in hypertension, we know that microvascular damage is seen at these different levels. Rarefaction, which is reduced density of arterioles, capillaries, and venules in tissue organs. Enhanced constriction and reduced dilation of arterioles. And eutropic inward remodeling, which is a situation where you see a decreased arterial diameter and increased wall to lumen ratio of small arteries. The first three are structural changes in the vasculature. The last one is a microvascular dysfunction related to nitric oxide, and we'll touch on it. In eutropic inward remodeling, smooth muscle cells reorient themselves, and this is what this depicts the pictorial change. You see increased number of smooth muscle cell layers, decreased external and internal diameters, and we see overall presentation of this throughout the body in different organ tissues. Of course, the hallmark of changes related to activation of the enzymatic and non-enzymatic sources of reactive oxygen species in the endothelial cells, also in the smooth cells, is reduced nitric oxide availability. And there's papers and books that have been written on this, but basically this is involved in the process. We have a compensatory mechanism that accounts for the low nitric oxide that leads to endothelium-dependent vasodilation, which partially maintained by production and release of the endothelium-derived vasodilators and then nitric oxide, such factors like prostanoids. Continuing our visit with a mechanism, we also see as a response in hypertension adrenergic activation overall, and this leads to prolonged vasoconstriction, which leads to effects, the effect due to the sympathetic nerve system, myogenic response, and locally produce or circulating substances, and all of these lead to microvasculature remodeling, and refraction, as I mentioned before. So in the brain, they have been quite advanced in looking at this, and I will show you my part or my involvement in studies in a minute. But basically, we know that in different processes that we'll just touch on them, we see structural and functional alteration related to atherosclerosis, liphoalinosis, hypertrophy, remodeling, wall stiffness, as well as functional hyperemia, endothelial-dependent vasodilation, problems with autoregulation, and all of this leads to compromised blood supply. And in the brain, they've linked it directly to stroke and dementia. I have gone over these with you. I'll just clarify that atherosclerotic plaques in the brain, in cerebral arteries and arterioles, lead to occlusions and ischemic injury. And this fibrinoid necrosis, which I mentioned, penetrating arteries and arterioles supplying the white matter, leading to small white matter infarcts of the brain and leading to hemorrhages. And maybe there are lessons here to take to the eye. In terms of hypertrophic and eutrophic remodeling, again, we see systemic or cerebral vessels, which are potentially damaged because of reduced vessel lumen and increased vascular resistance. And that, again, leads to vascular insufficiency. I mentioned the brain because there are a lot of similarities in control in cerebral and ocular circulations. And our group has published a few papers that looked at brain and eye blood flow. Some of my publications originally, or my work originally, was actually looking at patients in examining blood flow in the eye and with a Doppler in the brain as well. That's work that was done with Riegelstein, who's a neuro-ophthalmologist in Cologne. And here you can see a list of these similarities. And so you would expect retinal vessels many times to behave like some of the brain vessels. And you can see the midcerebral artery in this paper of ours in American Journal of Ophthalmology in glaucoma patients is showing reduced flow. And now you can also see reduced resistive or resistivity, which we saw both in cerebral and in the retrobulbar vessels, the ophthalmic artery, the central retinal artery, and the PCAs. And this was affected by CO2, was also affected by Diamox, systemic carbonic anhydrase inhibitors. And then when we superimpose CO2 in these patients with carbonic anhydrase inhibitors, we even saw a stronger effect. We saw similarities between the retrobulbar vessels and the cerebral vessels. So this makes us think that what they see in the brain and what they do over there could be pertinent to what we can do in the eye. Systemic hypertension and ocular measurements with OCT angiography. This is a review paper where we looked at all the different papers. It was a 2021, but certainly concluded that there are significant decreases in vessel density in the optic nerve head, peripapillary vascular layer, as well as in the macula of glaucoma patients. This is very interesting, and I want to take this one step forward. Here you can see a paper by Lim, and you can see an example. The top row is a healthy individual. The lower one is a patient with hypertension for 10 years who had no other systemic or ocular abnormality. And you can certainly see how you have differences in vessel density, perfusion density, as well as an enlarged foveal avascular zone in the patient with hypertension compared to a 62-year-old matched age healthy individual, as an example, on the top row. It's interesting that the hypertension vascular changes that were documented with the OCTA were also paralleled with changes, lower ganglion cell inner plexiform layer measurements that were seen. These are different studies that I got together for you, and you can see there's more than maybe you would expect that look at macular vessel density of the superficial retinal layer as well as the deeper retinal layer, and decreased that are decreased in hypertensive patients. This is a really interesting report that looked at OCTA images of patients with hypertension. So basically what you have is you have patients, they studied 118 adults, and this is an example that had essential hypertension that in this study was defined as, and there's a typo here, it's not 120, it's 130 millimeters mercury. OCTA was used in conjunction with cardiovascular magnetic resonance to look at parallels. And you can definitely see that the superficial capillary density map is altered and lowered in the top patient. That also shows parallel left ventricular short axis view of remodeling of the left ventricle, as well as extracellular volume map, which is enhanced, as well as a global longitudinal strain index, which is being impaired. All of these are measures of lower contractility of the left ventricle. So you can see that the changes seen in these hypertension patients are actually manifest themselves in these heart measurements as well. And this data suggests that there is a correlation between these different indices of heart function in hypertensive patients. When you look at the index left ventricular mass, the index volume, as well as the global longitudinal strain, which is an index of contractility, and showing you very nice decreases in the superficial capillary density, suggesting that these changes that we see in these patients taken by OCT may be used, as they conclude, as an index of microcirculation alteration of vascular risk factors in generally. I want to end with the last chapter, which might just give an insight as to where we might take this. So clearly, I think you're convinced that blood pressure, I mean, it's complex, but blood pressure plays a role, high and low. How can we use this? How can this be interpreted? So we've been using mathematical models that are used to actually help us in moving away from the individual observations or population-based studies or the clinical studies. And what we do is we have designed a physically based mathematical model which actually calculates blood flow in retinal and in the vasculature of the eye. And it leveraged the analogy between blood flowing in a network of vessels and current flowing in a circuit. It takes into account venous collapse and can simulate the relationship between changes in IOP, collapse in veins. This is a phenomenon in physiology that we relate to as a Starling resistor. It can also take into account autoregulation differences. And basically, it can simulate flow in these vessels. And what you can see is you can see as an example of the model, we published papers in IOVS 2014, 2015 for validating them, but you can see an example of 3 patients, low, normal, and high blood pressure, where we can alter intraocular pressure and look at the hemodynamic response in all of these patients. And we can see that when intraocular pressure is artificially varied between 15 and 45, basically you can see the high tension patient and the normal patient with having a plateau early with early IOPs, and then as IOP increases, you can see these slopes until the point where there's actually lack of a venous collapse that is seen with a patient in green with low blood pressure. So you can see that lower than 26, the blood flow plateau, and then except for the patient with low blood pressure, between 26 and 36, you see the same slope, and higher than 36 millimeters, you can see the venous collapse in the patient in green, which has low blood pressure. This was seen also in the Singapore eye study and confirmed. So they have concluded that their data matches our theoretical model and in predicting that individuals with both low blood pressure and high intraocular pressure are even more susceptible to dysfunctional regulation of blood flow. And where we finally took this, the next step is to trying to see if we can use blood pressure and intraocular pressure to predict progression. And what we did is we had our Indianapolis glaucoma progression study where we followed patients for 7 years. We use the model now just a bit differently. We actually insert the data from the blood pressure and IOP from the baseline visit into the model, and we can enhance the data to receive other vascular parameters such as total retinal blood flow, blood pressure in the arteries and veins, as well as blood velocity in the central retinal artery and vein. And basically, these are the parameters that we can enhance from systolic blood pressure, diastolic blood pressure, intraocular pressure, and heart rate. We don't necessarily need to use heart rate in the model. Again, the data came from the Indianapolis progression study. These 12 new variables that are achieved from enhancing the data are run into an unsupervised machine learning model, fuzzy C-means, for clustering algorithms. And that helps us identify patient clusters with similar ocular hemodynamics based on the blood pressure IOP relationship. And basically, this summarizes what we do. So the data of IOP and blood pressure goes into the model. We enhance the data. The data is run through the unsupervised clustering, fuzzy C-means, into a 12-dimensional data set, including the variables that I mentioned. We then use TSNE, which is a technique to visualize the data, as you can see here. Why is this fascinating, at least to me? If you look at the relationship of intraocular pressure and blood pressure on the lower bar on the left side, you can see that there's no special association. They all cluster together. But when we enhance the data set and we run it through the machine learning, as I said, you suddenly can see clustering that appears beautifully in the 12-dimensional, and then you can actually plot it and you can see different colors. We then use support vector machine to actually try to define these different sectors. And what we find is the green, the blue, and the red for IOP and blood pressure. And this is really fascinating because when we look at our own data over 4 years, and we look at the baseline IOP, blood pressure, and heart rate, we actually have 3 groups. Cluster 1 that does not progress, cluster 2 that progressed a lot, and cluster 3, which sort of progressed on some parameters, but not on others. When we then specifically try to go back to our data, we find that the red are patients with high blood pressure, which is the theme of my talk, that was found to be associated with progressing glaucoma, regardless of intraocular pressure. So if you look at the red dots, you cannot maneuver these dots back into the green area, really by maneuvering intraocular pressure. You can do that by changing blood pressure. If you look at the green and the blue dots, you can't shift their position much, or you can shift their position into the green by actually altering intraocular pressure. So the class 3 boundaries are tilted, especially for low blood pressure, suggesting the co-regulation in those patients of blood pressure and intraocular pressure. Of course, I'm bringing this to a closure. We need more data sets to account for medication, account for demographics. This is sort of pilot work, if you will, that suggests to you that we may be able to have some prediction of our patient's progression based on these two parameters. It's not device dependent. It's based on IOP and blood pressure and model estimated hemodynamics. You can use different devices, and the model will be affected by the specific study design and devices that you use, and might have some predictive capability. So today I've shown you that systemic hypertension and hypertension both play a role. Their association of where and when is complex. We saw that high blood pressure definitely has an impact on glaucoma. Combining math models and machine learning for predicting progression based on IOP and blood pressure maybe will have some important clinical utility. The road is long, and this is from a marathon swim I did in the Red Sea not so long ago, and it's there to remind us that we've done some distance, but we still have a lot to do with math models and artificial intelligence. And the problem is we have to be careful from situations and problems related to hurdles we might have on the way, like jellyfish. So thank you very much again, appreciate it.
Thank you, Alon, for describing a very complex topic, and also for providing us a possible path forward to understanding this better. So, the Glaucoma Foundation think tanks all boil down to one thing, really. How does this affect the patient, really, and how can we keep them functional and feeling that they're not visually impaired? Studying that has been an extraordinarily difficult road over many years, and has taken a lot of innovation and hard work. Pradeep Ramulu from Hopkins has, of course, been a leader in helping us understand what our patients experience on a day-to-day basis, both creating innovative ways to study it, but also possibly ways to ameliorate their visual difficulties. With that, I'll turn it over to Pradeep to assess the impact of glaucoma on activities of daily living.
Great. Thank you, Jeff, and Lou, congratulations. Really happy to be here to celebrate you. So I'm going to take a little liberty with this topic and maybe go in some directions that I don't normally go with in this talk. And I think we have a lot of very smart people over here, and so I really want to generate a discussion more than just tell you what I found. These are my disclosures, and some specificity on the degree of those disclosures as well. So I'm going to show you a lot of what I've done in one slide, and I show this slide a lot. And this is a really nice one if you're ever going for funding agencies or things of that nature, where we can kind of describe in centered models, how much worse you function in various domains if you see a little bit worse on your visual field. So you're more likely to stop driving, you read slower, you fall more often, you do less physical activity, and you don't leave home as much. And you can quantify this. And I often get asked, well, how much loss is a significant loss? Well, I don't know. I wouldn't want to go negatively on any of these parameters, but the more you lose, the worse off you are in all of them. And so there's no magic number. I think that we sometimes think of damage as a cross-sectional effect, but we shouldn't think of things that way. We should think of things as when you have more damage, not only are you worse off where you are right now, but you age faster. You get worse over time. So in other words, every year hits you harder when you have worse vision. This has been shown by a number of studies. This is Felipe's work, which was really nice, which actually showed that baseline visual field damage was associated with a more rapid change in your NEI VFQ score. And this is independent of what your change was. So in other words, if you were worse off to begin with, you got worse faster. In other words, you aged, each year hit you worse, even if you didn't get any worse. And so we have all these patients who come in and say, doctor, I'm seeing worse, and their visual field is exactly the same. And I think this is part of the reason. we found kind of an objective correlate to this, so that we found that people who had worse damage at baseline, actually their gait speed decreased faster over time as well. And also there's a recent work by Bob Weinreb, which showed that not only was it confirming what Felipe found, that not only was it the baseline damage, was also the rate of change, which increased the likelihood that at the end of a 10-year period of follow-up, you would be more disabled as compared to less disabled. So in other words, you would be in the red zone. So, so we always assume that, when we study kind of the impact of glaucoma on activities of daily living, that, somehow that's going to lead to addressing it better. And I think I want to kind of like get past that fallacy. Like, I don't know that that's completely true. You can study it and describe it, but at the end of the day, is anybody actually enter better off? And, how do we actually get people better off is part of our research. And that's kind of what I want to focus my talk on today. And I think it's not necessarily true. You can study it and nothing can change. So, so how can we understand functional ability, IDLs, quality of life in a way that actually allows us to move the field forward in what patients actually experience? So there's a number of ways, a number of topics that I'll cover today. How has the field used ADL difficulty or QL measures? How have they been used in clinical trials, and has this been useful? Do we need to measure these objectively, or is subjective measurement enough? How are we going to actually translate some of this work or some of these instruments into clinical practice? And this is kind of my own personal idea about, some practical ways that we can really make it useful through detailed study. And I'll give you an example of that. Our organizations all say, and I think it's been mentioned, Jeff mentioned this at the beginning, that quality of life is central to what we do. So this is the American Glaucoma Society, that we improve the lives of people with glaucoma. The AAO says that we empower lives. If we empower lives, we probably make them better in terms of their quality of life. The National Eye Institute says that their goal is to improve quality of life. So we're all saying the same thing, but is it actually happening through the study of it? So, I think that this is how quality of life has mostly been used. And I don't think that any of this is bad. I just showed you a slide which I think can be used to justify funding or services. I think a lot of it's been done because the FDA says it has to be done. If you want to approve something, you actually have to have, a patient-centric measure of some sort. And I think in the UK, a lot of the clinical trials have said that you have to put as your primary endpoint, a patient-reported outcome. So this is, what's actually driving some of this. I don't say that that's bad, but this is why a lot of this has really been taken up. So this is just one example from the TAG study where, in the introduction, I think that, if you look at the introductory sentence of papers, probably the two most common ones are, what is the prevalence of glaucoma, which we all know. And now maybe the second most common one is that it actually affects daily living. So I appreciate that they, cited one of my reviews on it, but at the same time, we all need to get past that and actually do something about it. So this is, these statements are kind of telling the reader what they already know, that preserving vision is important. And I think that it's good to have that justification. The FDA really strongly encourages patient-recorded outcomes as well. They actually say that what they really want is clinical outcome assessments. But if you look at what clinical outcome assessments are, there's things such as performance outcomes on the bottom there, which is something like visual acuity, but also patient-reported outcomes. So, I think there's a real emphasis that you really need to have both of these now. And pretty much every trial that's supported by the FDA is going to have one of each of those. So, unfortunately, this has become created an industry into itself to generate patient-reported outcomes. This slide is actually a couple of years old, and so these numbers have even increased further, where there's more than 50 patient-reported outcome measures validated for the use in glaucoma. There's actually 6 reviews of these outcomes, and then from 2013 to 19, there were still 6 more, and I'm sure there were a few more after 2019 as well. So we just get more and more of these measures, but what is it doing? Well, let's talk about clinical trials, because obviously if we have the idea that if we incorporate quality of life for patient-reported measures into clinical trials, that clinical trial is going to give us more information, and we're going to be able to use that information better to actually guide the treatment of our patients. But is this actually true? So let's take a few examples, and this is the LIGHT trial, where they actually use the EQ5D as the primary outcome measure. And what they found, so this was the primary measure, and actually secondary measures were things such as clinical effectiveness or cost effectiveness. And maybe not surprisingly, they didn't find any difference between laser and drops, nor did they find any difference between a glaucoma-specific quality of life measure. So in some ways, this wasn't all that informative. I guess you can say that you're certainly not hurting anybody by using drops, but it hasn't maybe told us as much as we might have liked with this outcome. Well, what about EAGLE? This was one that actually had a positive finding, so does that make it any better? So it found that there was a decrease in EQ5D in LPI patients, but no change in patients who had clear lens extraction. And this was a statistically significant difference. So it's not that lens extraction improved people, it's just that the laser seemed to be associated with a bit of a lowering in the EQ5D scores. And of course, there's maybe some reasons for that. The patients who had clear lens extraction were on fewer medications, even if their vision wasn't any better. But I think if you look at what is in the EQ5D, it's really hard to believe that this would be affected by an iridotomy and maybe being on an extra eye medicine. These are the questions. I didn't make this up. So it's mobility, being able to care for yourself, do your usual activities, pain and discomfort, and anxiety and depression. I think the only one that you could even really hypothesize might be a little bit affected is pain and discomfort. But those other ones certainly are not going to move at all, with an LPI and being put on latanoprost. And even pain and discomfort, there's an average of one medicine. It's hard to believe that really could drive such a large change in the score. And 0.04 change is actually pretty big. If you look at actually an explanation for this, well, why is this the case? Well, if you think about who would be enrolled into EAGLE, it would be people who actually say, I'm willing to get either an LPI in medicines or a clear lens extraction. But if you ask my patients, would you get a clear lens extraction? They're going to say, well, I have to get a surgery and all those things, whereas I can just get this laser today and maybe be on a medicine and be fine. They're not going to want the surgery quite yet. Most of them. Some of them will, but most of them won't. And when you get those people who will, they're kind of different. They're a different type of person. They're the person who says, oh yeah, I can get a procedure and just be done with this. That's great. Why don't you sign me up for that? And the inferences you're going to get from that group are not going to necessarily apply to everybody in the population. So this is who agrees. Surgically eager, medication averse. It's kind of a selected and biased sample. And this is probably who was in the study to begin with, because if they didn't want clear lens extraction, they wouldn't agree to be randomized. Well, I think sometimes I'm kind of painting a negative picture, but I don't want to too much. There are certainly sometimes situations where it's useful to know that therapies can improve both vision and quality of life. This is one example. So this is Humira, which was shown in the visual 1 and 2 trials to improve not only treatment outcomes, but visual functioning, which in this case was NEI VFQ-25 scores. And I think it was useful to know that it benefited quality of life beyond treatment success and acuity, even in the setting of an immunosuppressive. This is not always the case. If you look at UKGTS, they actually didn't find any change in quality of life measures between the placebo and treatment. And so now you're comparing an untreated group compared to a treated group. And only when you really look at the stable and progressing patients within that cohort did you actually see a difference. And even then, you only really saw it when you looked at a glaucoma-specific questionnaire. So, you have to keep in mind some history. So there's actually, you're going back, somebody mentioned this to me when I was asking a question of, has anybody found, a quality of life measure with a surgical intervention? There was, for macular translocation. Does anybody know anybody getting macular translocation right now? No. So, so there's actually a positive quality of life outcome with retinectomy and macular translocation. But actually nobody does the surgery anymore. So even despite this positive finding, the surgery has gone by the wayside. So what does that mean? This is one that I really like to quote because it actually, quality of life outcomes can be quite confusing or contradictive. This is a randomized trial for peripheral artery disease where they did exercise versus stenting, peripheral stenting. And what they found is that the people who did exercise actually walked better. So they had a better clinical outcome. And the quality of life increased in both groups, but the quality of life was better in the people who were stented. So in other words, people just like getting a stent and not having to exercise. So, but the thing that actually improved their outcome better and probably was better for their health and their longevity was actually less preferred. And maybe they just don't want to exercise. So how do you make quality of life outcomes better? I think this requires a lot of thought. So this is one idea that I think when we think about interventions, we really need to think about how you get from point A to point B. The problem with looking at quality of life at 2 time points is that it doesn't describe the journey. So, this is kind of going back to, energetics and physics, that you have the state function versus the path function. So the state function, it only depends on where your initial and final state of the system is. It doesn't matter how you get there. So this is like potential energy or temperature. It doesn't matter how you do it. And this is, I would also say, like IOP and quality of life, right? But the path function depends on how you get there. Do you have to like climb these, impossible groups to get there? And it can be a lot of work, but you do get there. It's just a lot of work. And so these are things such as like work and heat. So these are the physical examples, and cost and quality of treatment are other examples as well for a path function. Well, so if you just look at, for example, things like IOP drops versus SLT, yeah, they might get the same result, but with IOP drops, you need thousands of drops and hardly any for SLT. You need pharmacy visits. You have irritation and redness, and you may need a few more clinic visits. But then anyway, it's certainly a lot easier to do the SLT, right? But it's not really captured if you just look at the before and the after, which is what the study did. Well, this is a study done by my colleague, Amanda Bickett, who actually looked at this questionnaire of where they had people just describe on a visual analog scale what their functioning was. And we compared this for different procedures, and it kind of tells you what you would guess, that, things such as like cataract, you get better like really fast. And even trabeculectomy, it's slower, but it can be a better trajectory. And in tube shunt, it really takes people a long time to recover. So if you just looked at the final point, they'd all kind of be the same, but like the trajectory is quite different. And quality of life measures are not picking that up. So how do we capture that experience, that path function, if you would? I think there's certainly a lot of other opportunities for better integration of quality of life outcomes into trials. Can we measure things more precisely? We think so hard about how we can measure an OCT or a visual field better. Do we give the same amount of thought to how we can measure a quality of life questionnaire better? No, we don't. We have to have faster testing so we can do this more often, and so it doesn't become a burden in these studies. We have to assess multiple domains. It's not that everybody's mobility is going to get better. It may be their inconvenience or their costs or other things as well. And I think we just need to be thoughtful on how we detect change. Do we cluster testing like we do for visual fields? Do we do repeat same-day measurements? I mean, these are the things that we've incorporated into our vision testing, but we've not even thought about with regards to our quality of life testing. Well, what about objectively measuring things and subjectively measuring things? Are activities of daily living and quality of life the same? Well, quality of life is an individual perception of how you do your activities of daily living. So they're related, but they're not exactly the same. But I would argue that in some ways they're quite different. There's a reality of what we have, poor vision, discomfort, cosmesis, cost of care, time. And then there's the suffering related to that reality, which can vary dramatically across people. So, these things can, but don't necessarily need to, lead to problems with mood, anxiety, disappointment, frustration. And so a lot of that is not only how we view things, but it's our graceful acceptance, it's our attitude, and it's how we are treated by our care provider. The reality is that reality and suffering are quite poorly correlated. So this is a study that we did, which looked at correlations of all these different objective functional measures with self-reported quality of life. And you can see the R-squareds are like pretty low. They're generally 0.2 to 0.3. Which is pretty low. And if you just look at the demographics alone, that's about 0.1. So it's really not adding much to what you would know beyond just the person themselves. This was a pretty interesting set of findings that we're just exploring right now, that actually, if you look at like what accounts for this discrepancy between what people say they function and how they actually function. In one study, we were looking at actual visual difficulty and self-reported visual difficulty, and people tend to complain less when they're older, poor, of a disadvantaged group, or they're less educated. So in other words, these people who are in these groups say their quality of life is fine, even when their poor vision is poor. So they've kind of come to accept less from the healthcare system, which is actually quite problematic to kind of infer their quality of life in that setting. Similarly, in our glaucoma cohort, we actually looked now at the discrepancy between how they functioned and how they said they functioned, so their self-reported quality of life, and looked at what accounts for that discrepancy. and people actually kind of function worse than they say they do when they're African American or less educated or living in a high area of higher deprivation. So again, these people are not complaining as much, which is a problem. Well, how do you, what predicts quality of life? I think it actually tends to be something else which is self-reported. So, what the patient says predicts what the patient says, and how they perform actually doesn't perform nearly as well. This is maybe not so surprising, as if you actually look at what glaucoma quality of life it is, it's mostly mobility. Almost all the questions here are really mobility questions. Well, how do we actually translate and start using this in clinical practice? I mean, so I gave you kind of this, this lot of complexity, and I think there actually are some very practical ways that we can explore in using some of these quality of life and activity of daily living measures in our daily practice. So I think that we can certainly use it to guide what we talk to patients about, to evaluate our care, and we can do this across a single person, across an institution, across systems. Well, what about guiding what we communicate about? I mean, there's really a lot to talk to patients about in a clinical encounter. You got like all these things over here, and you got to do it all in 10 minutes. It's tough, right? Our days are stressful. So, and there's the routine stuff, that we have to really cover every single time. There's probably stuff that we don't want to talk about because we know it doesn't really affect them that much. Their dry eye, their side effects, their visual phenomenon that are bizarre that we can't explain. And then there's all the other stuff, which is really important, but we just don't have any time for. So I think that a good questionnaire can actually tell us what we need to talk to patients about. So this is work that my colleague Mona Kaleem is doing in collaboration with Ecos Lamoureux and Eva Fenwick, where a patient arrives in clinic, they respond to a questionnaire, and then that score kind of provides us a snapshot of where they might be having problems. So when we start talking to them, you can actually say, oh, I see you're having a lot of trouble with the cost of care. Are there some ways that we can do something about it? So you can maybe do one thing that you might have an extra minute or two for, as opposed to really addressing a smorgasbord of issues and you don't even know what they are. So, so this is really some very nice work that had been done, where the Ecos and Eva's questionnaire really took all the questionnaires that were generated and all the questions from all those questionnaires, and they grouped them into different activities, such as limitation, mobility, symptoms, surface symptoms, convenience, health concerns, emotional, social, and economic. So they really thought about this very carefully. And this is now a compendium of all questionnaires that have been created for glaucoma. And they used a computerized adaptive testing mechanism to really measure ability across these domains. So, they're trying to measure in a few questions, as you would normally do, what is actually somebody's ability. So if I'm going to try and figure out how much you know about something, I'm going to start with an average question. If you get it right, I'm going to go harder. If you get it right, I'm going to go harder again until you start missing it, and then I'm going to go down and I'm going to bracket about where you're at. And in 6 or 7 questions, you can figure out pretty well what somebody's ability is. You don't need to ask them, like in the American board, 6 hours of questions that span, 200 different questions. So, you can do it a lot faster. And so this is how it is printed out. It's printed out on an iPad. And then you get all these scores and all these domains, and you can say, oh, well, I see you're having a lot of trouble with convenience. Maybe we don't need to see you as often, or you can be seen more locally. You can figure out maybe the reason behind that. So I think this can really transform our practice. We can identify patients who are, we can also not only do this, but also look at how they're functioning independent of their vision loss and see how individuals are doing. As a doctor, we can look at how systems of care are doing. And we can also kind of figure out solutions for all these areas as well, which sometimes we don't officially think about. Well, I'm going to go through this pretty quickly so we have enough time for discussion, and many of you might have actually heard some of these slides anyway. But how do you actually start really addressing the specific problems? I feel that just like a lot of the research you've heard this weekend, you have to dive down deep into the problem to really understand it and try and figure out how are we going to actually get those solutions to patients. This is one study that we've been focusing on, the falls in glaucoma study, really diving into the mechanism behind these falls. It's not always so simple as what you see on the right. And so you really want to figure out the methodology and figuring out like why individuals are falling. So this was a study where we really got a lot of data from patients, fall calendars, calls, accelerometry, geo-tracking, fields, home examination. These patients did a lot for us. We found about half of patients fell over the span of 2 years. We noted that you really have to analyze falls in a different way to understand them properly. So as with crashes, you can see that people who are older actually have fewer crashes, but they actually crash more per mile because they don't expose themselves to the possibility of crashes as much. And so we thought the same thing was true for falls as well, that you actually have to account for how much they walk in the first place. And so this is the way we modeled it, with negative binomial regression, with the amount of steps as the denominator. And in fact, this denominator is influenced by your field, by your glaucoma damage. So the worse your damage, the less you walk. And so the less you walk, the less you expose yourself to a fall. So if you do fall, you probably were especially at risk for it. I'm going to skip this slide to really get to some other ideas. We did find that people who had worse vision fell more per step, but did not fall more per year. And so you really have to look at these both together. Likewise, the gait parameters that are associated with a higher rate of falling are different if you account for steps or not. So you have to really account for steps. And so really the best measure is kind of both. You want to know whether somebody is falling more often per step or falling more often per year to really get the full picture. So, well, why are people falling? I think you have to really look at these questions very mechanistically and in a lot of detail. We thought it was because of worse balance, and people with glaucoma did have worse balance, but actually, and they also had worse gait, more anomalous gait, and a wider brace of support, and a greater variability in their gait from step to step. But actually, this didn't attenuate the relationship between visual field damage and fall. So in other words, if you included all these measures, the persistence and of the association between damage and falling persisted. So it doesn't seem that they fell because of their poor balance or because of their gait, although it doesn't mean that it wouldn't be helpful to fix those issues. It didn't seem like it mattered where they fell, so there was no particular area that was more related to visual field damage. We did find that a lot of falls occurred inside the home. In fact, more falls occurred inside the home. And in fact, if you look at where people walk, they walk more inside the home. So every step you take at home is actually more likely to lead to a fall than every step outside the home, which was quite surprising to us. We did find that visual field damage was associated with fall rates in and away from the home, and that falls away from home were more likely to cause an injury. So maybe they are important, but maybe in a different way. I think practically you can tell people where to be careful. So there are hot spots for where people with glaucoma fall: bathroom, stairs, bedroom. And these areas tend to have more hazards as well. I think what's really important is really understanding, well, what can you actually do to affect these rooms? And I think the big thing that really seems to stand out is lighting. So while hazards were not associated with the rate of falling in a given room, the better the lighting, the less you fell. The better the lighting, the better. And there was no clear right amount, although we suggest to people now that they increase their lighting to 300 lux. We also found that home lighting was associated with how much activity they did. So in addition to not only falling less, they may actually do more activity also. We find that people don't change their homes for falls. So if they have more advanced damage, they still have the same number of hazards and they still have the same amount of lighting. So I'll skip that as well. So thanks to my team, and let me leave some time for discussion.
For the scientists, physicians, in the room, the work that we do filters down to the patient level, right? And that's why we're here. The impact of medicine, treatment of hypertension, for example, the way we practice, the impact of what people eat and drink and so on, how they live their lives impacts the disease process, and how they perceive it and its effect on their ability to function are all linked together. George Spaeth, one of the philosophers now of glaucoma, really has talked for a long time about just the act of making the diagnosis impacts the patient. And we have to be careful about all the things we do for the patients, how we examine them, what we say to them about their disease, and it impacts the quality of their lives. So with that in mind, we have enough discussion time here for 2 days, but we're going to have to limit it to 15 minutes. So with that, I'll open it to questions, but as we bring the microphone up, let me just start it off by saying we know a lot about, we've seen a lot of information about diet and talking to patients in the office, but without the underlying genetic information about the individual patient's responsiveness to some of these things that they intake, food or other items, can we really advise them at this point? Is there any advice we can offer patients about lifestyle or nutritional change? I'll ask you, Jahi, to start it off, but it's open to the panel and the audience, of course.
Right, given the emphasis that we've given on how effects could be totally different by one's genetic predisposition, it gets challenging, but I think it's reasonable to go with what's generally recommended for maintaining general health, and then sort of modulating based on what's known about the patient. So, for example, there's a great emphasis on the Mediterranean diet. So eat healthy fats from olive oil and nuts, eat whole grains rather than sugary beverages or refined sugars, and eat more fats, eat more fatty fish. So there, for example, if we were talking to an average patient, I would imagine that those kinds of recommendations would be good. If, however, patient has low blood pressure, because the MIND diet, the DASH diet certainly was designed to lower blood pressure, that might need to be modulated. And so you might say something like, eat green leafy vegetables and, berries, but don't overdo it because of the, high potassium. For example, avocados are really high in potassium, lower your blood pressure. So if it's somebody already low, maybe add some additional recommendations. If somebody has high blood pressure, maybe encourage more moderation in alcohol or caffeine.
So in daily practice, of course, the patients are asking us, can they have coffee? Can they do all sorts of other things? What should we tell them? Maybe the audience, clinicians, what are you telling your patients about coffee consumption? I'll start with you, Anthony. Oh, sorry. Sally, Anthony. Ladies first, Sally.
I guess everything in moderation is kind of my life's philosophy. But yeah, I think it's hard because these diet fats come in and out. And so people come in with different questions. I've had patients ask about, like, can I do yoga? So that's in Southern California, a lot of people do yoga. So I think that's, inversion postures and things like that. So I think that comes up as well. But it's hard, I think, to keep up with all the evidence and the changing guidelines. And it seems like there's a new thing every couple of years, low fat versus low carb. And so I find that to be a little bit difficult. So I usually just say everything in moderation. It's kind of, what you say your mom.
We've heard from the information specialists and the national Bush is the hedge. But I'm going to ask you to be very specific, Anthony. What do you tell your patients? And I ask everyone to keep their comments kind of brief because we don't have that much time and it's important.
Okay, so if a patient's got stable glaucoma, fairly mild, I say, look, this probably doesn't matter. If someone's got advancing glaucoma despite my best treatment, I say, well, look, there's this evidence, it's not certain, but it might be that limiting your caffeine and alcohol consumption will help you.
So do you ask them questions about their blood pressure control?
Yes.
You do. You're looking for high blood pressure or low blood pressure?
That was one thing I was actually going to ask for the panel, which is, when Alon brought up the machine learning model, I had a very similar model where we only looked at systemic data from the electronic health record, no IOP, no corneal thickness, nothing else. And that was one of the variables that drove our prediction model and actually had reasonable performance, even in the absence of eye data. So I wonder, we don't routinely measure blood pressure at eye care visits, at least not in the United States. Should that change? Do you think there should be more advocacy around that, especially with the new regulation or the new definitions where something like 50% over people, and people over the age of 50 are going to have hypertension based on the new definitions?
I think that yes, of course, but not only from the perspective of the data that I presented. I think if you look at my colleagues and you go back to their talks, everything that was mentioned is going to impact on a lot of what was mentioned is going to impact glaucoma or intraocular pressure in the sense that exercise does. We've seen the data on caffeine, right? We've seen the data on alcohol, better diets. But going back to hypertension, I think that I appreciate the opportunity because I think that hypertension is not well presented enough in our discussions in glaucoma and the pathophysiology. We focused on low blood pressure because that's where the population-based studies took us, and the thought leaders. I think the data that we showed clearly suggests that this is something that needs to be incorporated. There are a lot of clinics around the world that do measure blood pressure. I think US is a bit behind in that regards.
So Pradeep, let me push this down to you a little bit. Patients know a lot about their blood pressure control. They can see internists all the time. They're treated or not treated or overtreated. Based upon the evidence, do you tell your patients to cut down their caffeine consumption? Just yes or no? I mean, I want you to, this is an important issue for patients, many of whom are watching. Do they need to, limit caffeine consumption? Do they need to do anything besides moderate their activity? Which we tell every patient, every doctor in the world tells every patient for every disease.
And with Anthony, in the vast majority, no. And of course, by telling those things, you're affecting their quality. I mean, if you actually tell them that, you're affecting their quality of life.
Right.
So, you might eventually, many years down the road, you may or may not improve their mobility or their reading or something else, but they're not going to be able to stay awake tomorrow if they can't get their caffeine. So, that quality of life impact can be immediate.
Let me ask you another question then. Based upon your understanding and patient experience, which is the bigger problem for the glaucoma patient long-term? Hypertension, because most of them are treated when they know they have the disease, or overtreatment of hypertension or systemic hypotension that's untreated. A little old lady who comes in who's 85 years old, the pressure's 10, and her blood pressure is extraordinarily low. Those are the most difficult patients there are because of perfusion issues. Which is the bigger problem?
I mean, I agree with Alon, what Alon was presenting, that it's the overtreatment that seems to be the problem. But unfortunately, that overtreatment has medical benefits as well. And then I think a lot of people talk about not using antihypertensives at night, but then actually one of my colleagues' wives, who's an internist, told me that it's actually the nighttime treatment which has been proven to be better for stroke prevention. So it's like you can't even tell them that. So I'm always very hesitant to do something which could increase a systemic event.
I think it's important to communicate with internal medicine to make sure that they're being treated. The pressure's not too high, not too low, it's just right. Before you answer that, though, Simon,
to address your point.
Oh, sorry. So Simon has been waiting.
I wanted to add into this discussion about what you recommended in blood pressure, and I enjoyed all of your talks, but Alon, is there any evidence for the nature of the anti-vascular hypertensive medications and if they have differential effects? For example, angiotensin ACE inhibitors, Ang2 inhibitors, they could be having intracellular effects in neurons as well as the blood pressure effect. So is there any evidence there's particular classes you should recommend your patients to take or not take, so to change their anti-vascular hypertensive medication regimen?
Anthony has a meta-analysis which is coming out on that, so he should comment.
Anthony.
Yeah, no, now in multiple different studies, actually, we're finding calcium channel blockers seem to particularly have an adverse association. It's not cause and effect, but it's come up in multiple different studies now. So amlodipine, nifedipine.
Simon, I think you bring up a very important point. We tried to look at and I mentioned in the talk, we'll come back to it in the discussion. In the Saloniki study, we tried to look at the different subgroups of medications. Unfortunately, we didn't have enough patients in each, which is the problem, I think, with some of these studies. So I'm looking forward to look at the biobank data from, Anthony's data, but I can tell you there's certainly physiological reasonings to think that different classes will have different effect. In cardiology today, there's, new classes of medications that actually, some of them are not, they're aggressive in lowering blood pressure, but they actually have an effect on cardiac function. And maybe those are the ones that you want to use, not to lower the blood pressure too aggressively and to maintain perfusion at the same time.
Of course, for the scientists in the room, a single drop into the eye has a systemic effect that bypasses detoxification in the liver. And a single drop of timolol can lower your heart rate and your perfusion. So these things, the eye can be sensitive, and there are studies that demonstrate differences with topical eye drops.
Is topical beta blockers potentially the reason why glaucoma patients have lower blood pressure, or the people who are progressing more have lower blood pressure because they're on more treatment? And could it be the topical beta blockers?
And for that reason, many glaucoma specialists only use a topical beta blocker in the morning and don't use it at night when blood pressure is usually normalized.
The answer is there are studies that show very, a systemic absorption that can actually impact on blood pressure as well, depending on the dosing. So it could be, and that could be the confounding in some of those studies.
Is there some surrogate we can use? You mentioned that, for patients at risk with caffeine, genetic risk, it's deleterious. Is there some office surrogate we can use? You mentioned sensitivity to the caffeine. Is there something we can actually do for our patients?
Just being in your clinic, because we're saying a genetic predisposition for the whole general population. I think by the time someone's in your clinic, they're probably selected for having a high genetic predisposition.
Okay, that's fair. Lou?
I would say that having 2 first-degree relatives with glaucoma is probably going to be equivalent to having a very high polygenetic risk score. And having a very high polygenetic risk score, patients are seeming to behave like a patient with a single Mendelian variant that's highly penetrant and has a high chance of producing disease. And those people should probably curtail their caffeine and coffee intake to 2 cups a day.
So we need that test, right? We need to be able to do that clinically to be able to assess that risk. Alon, you had a comment?
Yeah, I want to come back to what was said before with the blood pressure, because I don't feel that we have explained what I meant. I mean, if you look at long-term effects of blood pressure, it clearly, and that's what I tried to present, it has microvasculature damage that occurs, including autoregulation problems. So the problem is that for those patients that have been hypertensive for many years, until they treated, the damage is there. So that's what's going to come back. And even if you don't believe in the vascular component in glaucoma, it's going to come back and exacerbate the situation. So the acute, don't expect that the acute dealing with the blood pressure is going to solve the issue here. It will help for the years to come, but the damage might already be there, including, nitric oxide, lack of nitric oxide.
Anthony?
I'd like to ask Pradeep, for a patient with a given poor clinical status, what interventions can there be to improve their quality of life? As in, I think we're quite bad at that. Some of our patients unfortunately lose vision, and maybe we're not very good at trying to mitigate that so that they're still happy and have a good quality of life. Brightness was an interesting thing. Are there more things like that that we can tell our patients?
Yeah, I mean, the main thing I tell people is lighting. I explain the disease, a disease of contrast. In fact, a visual field test is a contrast test. You're just testing contrast in many different locations. So I describe it as a disease of contrast, and you can show them that if you put a light on something, then your ability to see them increases. I think that probably practically speaking, I think it's getting somebody and convincing somebody to go see a rehabilitation specialist. And, we found at Hopkins, that about like 13% of people who would qualify for a vision rehab appointment get referred for a vision rehab appointment. And that's actually rather high, so in the community, it's probably even lower. So these were people who were interested in doing that. So, there's a select subgroup of individuals. And so I think just, finding ways to make that conversation easier and simpler is really important. I think that, you have to believe it yourself. You have to believe that, seeing a vision rehabilitation specialist can actually help the patient. If you don't believe it, then you're never going to convince the patient. So, so I think you have to first have that belief, and you have to be willing to spend some time, unfortunately, to have the conversation. And it's going to be a couple-minute conversation. So, I understand why people don't have that conversation, because it takes time when we're already busy. But, honestly, when somebody's at that stage and their pressure is controlled, the thing that's going to improve their lives more than anything else is the ability to get to somebody who can help rehabilitate them.
Yeah, my opinion is for Pradeep. I mean, you're talking about activities of daily living. I think you're talking about referring patients to low vision specialists, but I think there's a lot of low-hanging fruit here where the specialist can even have in their office, and TGF can supply this, just a brochure that says, here's lighting recommendations for your home. Here's organizational recommendations for your home, for your mail, for the falling hazard. You know, is like I have 4 or 5 falls a year, and I don't think it's because of my blindness. I think it's just because I'm really messy. But learning how to set up your home and set you up for success with low vision before you're low vision, when in the beginning of your diagnosis, and prepare for these eventualities. But I think that's very, very easy for a specialist to have in their office, because like you said, only 13% of patients are referred to a low vision specialist. How can we help them in the meantime? Because that's, 87% are not being helped, and 87% are at risk for falling and reduced activities, burning themselves on a stove because they don't know how to move about their home safely.
I would also suggest for those people who may not be willing to see a specialist, Hadley, it's hadley.edu. It's a very, very good website, and it's also friendly for people who are visually impaired. It's very good, and it deals with every single topic you brought up: the emotional, the safety, the falls, the home safety, and so it has a lot of very useful resources.
So this is something that honestly should be made compulsory or automatic in every glaucoma specialist office or every specialist office, and that's the referral, whether it's a card or just giving them the website on their way out the door. I mean, it's very easy.
I mean, the program that I really I'm trying to convince our vision rehab specialists to do is to say that, because probably the best, as with most things, the best advocate for vision rehab is somebody who's benefited from vision rehab. So to say, well, I want somebody to call you to talk about, how to live better with the vision damage that you have. And they could say like, oh, why? Just because, they're going to talk to you about it and how they've lived with it. You may not know a lot of people with poor vision, and they might actually suggest some things that you might do to improve, your lot. And if you could find those volunteers who are actually willing to have those conversations with people, the conversation that we would have with a patient would be very short, but they would have a separate conversation with somebody who actually knows what it's about and who's had the life experience of it changing their life. And them talking to them is going to have a lot of effect, and probably would increase the referral rate even more than the doctor talking to them. That's my theory.
Agreed. I found out about hot pink duct tape for the edge of my stairs through a patient support group, and something like that saved me a lot of falls. So I agree. Yeah.
I think that this entire meeting, this session in particular, and the conversation here is a perfect segue into the next session, which will focus really just on the patients themselves, and we'll hear from them about these types of experiences. So I want to thank all the speakers for a wonderful session. We're going to reconvene here in 15 minutes at 10:15. Thank you.